This is an advanced case showing a parotid gland lesion. Remember that we talked before about the normal parotid gland with a superficial and a deep component. Now let's look at this abnormal hypodense rim-enhancing lesion that involves the inferior aspect of the superficial left parotid gland. The low-density center of the lesion is consistent with fluid. Now, primary parotid lesions such as Warthin's or pleomorphic adenomas could be necrotic. Metastatic head and neck lesions to the intraparotid lymph nodes could be necrotic as well. However, with all these primary or secondary parotid neoplasms, you'd expect to see more soft tissue enhancing components. The presence of this thin rim of enhancement with a central fluid component is highly consistent with an abscess. Now, this adjacent subcutaneous fat change and skin thickening is also highly consistent with an infectious process. Even more interesting is the presence of this low-density rim-enhancing tract-like abnormality that connects the skin to the intraparotid lesion. This tract-like abnormality is even better appreciated on the coronal image here. Such communication between the lesion and the skin is consistent with a sinus tract, which was easily confirmed on clinical examination. The patient had no enlarged neck lymph nodes or other lesions. So putting everything together, you'd have to favor an infection rather than a neoplasm. If the patient had a penetrating injury, this could be complicated by an infection and usually is bacterial in that case. However, the patient denied any history of trauma. So this brings up another important infection that could form sinus tracts and fistulas. By this infection, we mean tuberculosis. Remember that TB in endemic areas could involve any organ and have various appearances. This was a proven case of left parotid gland tuberculous abscess with sinus tract formation. This was a good case to revisit the parotid gland. Remember that it could be involved by neoplasms or infections. The cystic-like fluid density, rim enhancement, surrounding inflammatory changes, sinus tract, and lack of soft tissue components favors an infection. An infection that likes to form sinuses and fistulas and should be considered in endemic areas is tuberculosis, so always keep that in mind. Thank you for watching. Your comments are always appreciated. More cases later this week. This is a quick case to show a specific finding. There are no obvious lung abnormalities and there are atherosclerotic calcific changes of the aorta. The reason I'm showing this case is to concentrate on this finding. Now you could see this curvilinear density, which is relatively of high density and suggestive of calcifications. Such calcific density would be unusual for vascular calcification, is far away from the aorta, and would be unusual for calcification of the coronary arteries. Sometimes calcifications in the pericardium at the region of the left atrioventricular groove may simulate this appearance. However, this is relatively thicker than expected for most pericardial calcifications, and the rest of the pericardium does not appear calcified. Now let's look at the CT scan of the same patient. The patient does have coronary arterial calcifications which are difficult to appreciate on the chest radiograph. The area that we were interested in, based on what we saw on the chest x-ray, is this region here. Note how this chunk of calcium here is separated from the adjacent coronary artery, namely the left circumflex coronary artery. Also notice that this calcium does not involve the pericardium, which is thin and seen with difficulty in this case. That's the normal pericardial appearance. For orientation purposes, this is the left atrium, this is the left ventricle, this is the right atrium, and this is the right ventricle. So this makes these leaflets here the mitral leaflets between the left atrium and the left ventricle. It's important to notice that the calcification is adjacent but does not involve the mitral valve leaflets. Although not easily appreciated on a CT scan, the leaflets are attached to a fibrous ring, what we call the mitral annulus. So this chunky area of calcification actually involves the mitral annulus. It does not involve the entire annulus, it's only this part here. Mitral annular calcifications, especially in this location, the infralateral location, are very common, especially with aging. Such finding is usually not associated with any other abnormalities, and it's important to note that it does not involve the mitral leaflets. So seeing mitral annular calcifications is common and does not mean that the leaflets are abnormal in the form of stenosis or regurgitation. Now that we saw this, let's look at the same appearance on coronal imaging. I'm going from anterior to posterior, and here's your mitral annular calcification. Now it's easier for us to understand why this looks like what it looks like on a chest X-ray. And here's the chest X-ray again showing the same mitral annular calcification. So the diagnosis in this case was mitral annular calcification. Remember that this is a common aging finding. It's classically not associated with any other abnormalities, and it's seen with difficulty on frontal chest X-rays. Thank you for watching. Your comments are appreciated as usual. See you later. There are bilateral extensive abnormalities in this 38-year-old male patient. Compared to a normal brain, there is absence of the sulci, which are all effaced and compressed due to significant increase in the intracranial pressure. There are these areas of hypodensity where the gray-white matter junction has disappeared, seen anteriorly and posteriorly. More peripheral wedge-shaped opacities in the frontal and posterior areas are consistent with superficial watershed infarcts. The bilateral, almost symmetric parasagittal opacities adjacent to the midline are consistent with deep watershed infarcts. The combination of sulcal effacement and bilateral, superficial, and deep watershed infarction is consistent with a severe hypoxic ischemic event. In this unfortunate patient, this resulted from a cardiac arrest. However, this is not the reason I'm showing you the case. I will dedicate other clips to explain more on watershed infarcts, but the reason I'm showing you this case is to look at this area. Those are the lateral ventricles, which are compressed, especially posteriorly, by the effect of edema. You see part of the fourth ventricle here. The focal hyperdensity in the brainstem, namely in the pons, is a bit unusual. Now, with increased intracranial pressure from various causes, you could have various herniation syndromes, something else that I would dedicate another session for. One type of herniation may result from increased supratentorial pressure with the brain pushing from above below through the incisura into the posterior fossa. In a normal patient, you should see a CSF black density surrounding the brainstem. Here you don't see that, and this is a result of herniation. This type of herniation is called descending transtentorial herniation. Again, I will separate another session for talking about herniations. However, this focus here is related to what we're talking about. This density here is a true hemorrhagic intraparenchymal focus within the brainstem. The theory is that transtentorial herniation displaces the brainstem downwards, and this leads to rupture of small perforating vessels. Such injury to small perforating vessels may lead to this centrally appearing hemorrhagic focus within the midbrain or the pons. So this hemorrhagic focus is not the primary abnormality. The primary abnormality is brain edema and secondary transtentorial herniation. For the seniors, such hemorrhage even has a cute name. It's called Durette hemorrhage. So this is a nice case showing features of severe hypoxic ischemic events in the form of superficial and deep watershed infarcts, transtentorial herniation, and most importantly, the reason I'm showing the case is secondary diuretic hemorrhage. There are many neat and practical points that we could talk about when assessing patients with increased intracranial pressure, and we'll leave that for other sessions. Thanks for watching. More cases later.